Hello, welcome to this short lecture about the practical application of the RE-AIM framework. My name is Jaap Koot and I'm working in the Global Health Unit in the University Medical Center of Groningen in the Netherlands, and I've been coordinating several GACD funded projects. I will give you a short introduction about the SUNI-SEA project, scaling up NCD interventions in Southeast Asia. Then a few words about the RE-AIM framework, and then I'll give you two examples of how we use the RE-AIM framework in community groups and in the scaling up project. In the SUNI-SEA project, we looked at community interventions and primary healthcare interventions in the prevention and early treatment of NCDs. And we tried to achieve synergies so that there would be a flow of community activities and primary healthcare activities that would contribute to improvement of NCD prevention and control. And especially I draw your attention to the community part, because there you see activities like health promotion, screening and lifestyle interventions that we used in Indonesia, Myanmar and Vietnam. So later on I will tell you more about the community-based activities in Vietnam. The total project was about scaling up NCD interventions. And we know the horizontal scaling up, which is increasing the coverage, reaching more people, and the vertical scaling up, increasing the package of services, adding new services to existing services. Now you see the third arrow, that is improving and maintaining quality. In our initial analysis of activities that were taking place in Vietnam, Myanmar and Indonesia, we concluded that quality assurance was a key aspect. So instead of using two dimensions of scaling up in our project, we applied three dimensions. And I come back to that when I talk about using the RE-AIM framework for the overall project evaluation. I'm sure you have already studied the RE-AIM framework, so I will not go in detail about the framework, but you can use it for planning, research and for policy making, and it has a number of dimensions. First of all, reach. Do I reach the targeted population? Effectiveness. How do I know that the intervention did achieve what it was supposed to achieve? Adoption. How do we get institutional support for the intervention? Implementation. How do we do the quality assurance of the implementation? And finally, maintenance. How do we guarantee sustainability? How do we make sure that this intervention is going to be applied after the end of the project? So these five dimensions are very important to look at them systematically. In the SUNI-SEA project, we did make a choice for the RE-AIM framework because it is a standardized method of evaluation that is already existing for decades. So it allowed us in the project to compare between countries, between research arms and different aspects of the complex interventions. And also we could use it maybe for comparison with other projects, in our case in the GACD scaling up projects. As I mentioned, the model is multidimensional, so it makes sure that you do a comprehensive evaluation and looking at all aspects, and especially beyond the medical or healthcare evaluation, looking also at how the project is implemented, who is reached and how it can be sustained. So it makes sure that you keep all different dimensions in focus and not losing out on important parts of the evaluation. And it is very important, in our case, was very important to look at sustainability, because the implementation research of GACD is principally meant for changing policies and practices in healthcare. The RE-AIM framework is not a kind of cookbook guideline, but requires that you are creative and that you use indicators that are relevant for your own situation. So you must contextualize the indicators, but of course you must do it within the general guidelines, so that you maintain the comparability. And there's a big problem of making it too complicated, so you must try to keep it as simple as possible to make the data collection manageable. If you lose yourself, you easily formulate up to 100 indicators, and then it becomes very difficult to manage that data collection. It also is important that this is a mixed method approach, because not all indicators can be measured in a quantitative way, especially when you talk about maintenance, sustainability. You cannot measure that. You must try to get through focused group discussions or interviews impressions on what is possible to maintain the activity. So therefore you need a multidisciplinary team to conduct this type of evaluation. The first example that I gave you is about study of community groups in Vietnam. I mentioned in the beginning of this presentation about the synergy model of linking community interventions to primary healthcare interventions. And in Vietnam, we were working with so-called intergenerational solidarity clubs. Those are clubs in villages of around 60, mostly elderly people, who work together on health and well-being, economic sustainability. So it is a group that is working on solidarity activities in a broader context than just health. So we were evaluating how those groups were able to achieve and to continue the work that they were doing in the groups using this RE-AIM framework. So we had to make the specific indicators, and we needed to also look at activities which were not only medical but also related to health. So in the course of implementation of the project and working with these community groups for about 3 years, we collected routine data on the membership of the ISHCs and continuation of memberships and the composition of the groups. And then we conducted surveys every year on the members, on the satisfaction and on the health status. We also did screening of health status, including blood pressure, body weight, and other simple measures that the members of the ISHCs could collect themselves. And we did a survey under the management boards of each ISHCs to know how well they were on track on achieving the target. And next to the quantitative data collection, we also did qualitative data collection with focus group discussion, where we focused more on the well-being and the willingness to participate. And we did key informant interviews with members, with board members, but also with staff from health facilities, to know more about the expected sustainability and the continuation of these groups after the end of this project. So we finally put all the data together and formulated the findings in the RE-AIM framework. and we concluded that the ISHCs were able to reach many people, especially poor female and older people. And we noted that members of the ISHCs were very satisfied, and there was over 95% of participation in all health activities, so the interventions were effective. And we saw that there was an adequate adoption, and that healthcare activities and health promotion activities were really becoming part of the groups, not only because it was important, but also it was fun doing together cooking classes and working together on physical activities. So it was really institutionalized in the ISHCs. And we saw that the implementation increased over time, that people invented themselves more and more activities that could be implemented, and they were very enthusiastic. And it was also a nice spillover that non-members of the ISHCs also started to work on the same type of health activities and were able to benefit from the activity, even if they were not targeted. Of course, this is meant to be continued after the end of the project, and based on interviews we have very good expectation of sustainability. And we are now already nearly 1 year after the end of the project, and we get still messages from the ISHCs that they are continuing and even expanding to other villages. So with the RE-AIM framework we were able to get a comprehensive analysis of the groups and the different aspects of the RE-AIM. In the resources there's an article that one of our colleagues wrote about the ISHC evaluation. We also used the RE-AIM framework to evaluate the whole project. And as I mentioned before, the project was implemented in 3 countries, in Indonesia, Myanmar and Vietnam. And it was a very complex project with many different interventions. In the figure you see that we did interventions at community level, the NCD control program, the healthcare organizations. We did a lot of training and capacity building. We developed screening protocols, we developed treatment protocols for primary healthcare. As I mentioned before, the community activities with health promotion and screening. So it was not a simple project that you could evaluate with a few interventions and a few indicators. And of course this project was about scaling up, so it was the aim to measure what are the chances of successful scaling up after the end of this project. In the beginning of the project we realized that we were working with many different stakeholders, and we needed to do a mapping of the stakeholders first to know where we can expect change of the system through the interventions. I already mentioned the community groups, but then there were also volunteers and primary healthcare staff involved, the managers of the primary healthcare facilities, district and provincial health managers, and also local governments and provincial authorities, policy makers at national level. And what was very important, what we came to discover, is the importance of decentralization in the whole system. That many decisions that we thought were taken at the national level, in fact, were decentralized to local government. For example, on human resources or on funds for primary healthcare or community activities, decisions were taken at a local level. So you also must weigh what is the importance of different stakeholders for different decisions. So we ended up making a matrix of indicators according to the re-aim categories, but then also for the different stakeholders. And then, as I mentioned already before, when we were in this process, we developed over 100 indicators to measure everything. So then we really tried to simplify afterwards again, so that it was manageable to collect all the data. And we were already, for all the different interventions, doing evaluations, for example, after training or after screening. So with those data that we were already collected, we could fill a lot of this matrix. So you really need to work in a smart way if you have such a big, complicated project to make the re-aim analysis feasible. When it came to data collection, of course, we started at local level and guided by the country teams who did the data collection using the guidelines that we had developed together. They conducted focus group discussions and key informant interviews using the discussion guide that we all applied in all countries. And the teams at the country level aggregated the data from quantitative and qualitative data collection and interpreted the findings. But in order to come to an overall conclusion in a consortium meeting, we had a kind of focus group discussions, trying to come to common findings and common conclusions. So if you have this complex project in different countries, you make the framework before, but then in a decentralized way you collect the data, and then you try to bring that again together to come to a common conclusion. Based on our analysis using the re-aim framework, we came to the following recommendations of scaling up NCD interventions in low and middle income countries. And the first one is you can reach many people if you have community-based activities, screening, health promotion, and that it is very important that the primary health care supports those activities. But it requires a good definition of roles and responsibilities. Who should do the supervision, who should do capacity building, how should you monitor. So the organization is very important to make it feasible. Community-based organizations that are existing in many countries can be very instrumental and can be very helpful for the implementation. But local, district and provincial authorities have an important role in adoption. They must really make sure that these interventions are institutionalized and get the support after the end of the project. And of course, an important finding as well is that it is important to invest in such programs. It is not possible to maintain it based on voluntarism of community groups only. You need support, you need supervision, you need from time to time incentives to make people implement activities. So overall, the project was successful, and you find on the GACD website, but also on the knowledge and action portal of the WHO, especially on the NCD programs, you find some of our publications and activities. The RE-AIM framework was then very instrumental to come to a good evaluation and to come to clear conclusions that are now being disseminated globally. So some key messages for takeaway of this short presentation is that we use the RE-AIM framework for simple evaluation of those community groups, but also for the complex evaluation of the whole project. You must start with formulating which indicators you want to use for each dimension, and then implement the data collection in the course of the project, because then you get the best information. Doing an evaluation after the end of the project with RE-AIM is much more difficult. And then, of course, as we mentioned before, it is a mixed method, so you need a multidisciplinary team to perform this evaluation. Well, this was only a very short presentation, but on our website, SUNI-SEA.org, you can find all the protocols, the training materials, health education materials, guidelines, also policy briefs. So there's an abundance of information about this project. The publication of the final evaluation is not yet ready. We hope to have it in the coming months. But you can also write me an email. And of course on the GACD website you can find a lot of information on the project Scaling Up too. Thank you for your attention, and I hope this was useful.